Good afternoon, everyone present here. I am Faraz from IJCP Group. Welcome all the participants on today's webinar. That is on a very important topic, that is the Reflux Riddle, navigating VUR and recurrent UTI in children. As we know that this is a very important topic in pediatric age, we see lots of patients suffering from this reflux disease and also with reoccurrence of urinary tract infection. So the discussion on this topic becomes very important. So we need someone who is expert on this topic. So without any further delay, I would like to welcome Dr. Sanjay Chaudhary, sir. Let me share some of the achievement of sir. Sir has done MD and he is senior consultant at Pediatric Department, Fortis Healthcare, Jaipur. So without any further delay, I would like to welcome sir and hand over this webinar to sir. Sir, stage is yours. You can proceed from here. Over to you, sir.
Thank you, Faraz. Thank you, IJCP, for allowing me to use this forum to discuss about various pediatric problems. One of the foremost pertaining for this time is urinary tract infection, which is one of the commonest cause of sepsis or infection of significant intensity, where admission is rate is quite high, is urinary tract infection. And in the big bunch of this urinary tract infection, a small segment remains with the recurrent urinary tract infection, where the likely causative etiology is vesicoureteric reflex. So today we will be discussing about UTI in general, and we will be discussing about VUR and its implications. Yeah. So how to prevent this, and if there is, how to manage it. So UTI is one of the commonest bacterial infection in children. Uh, the risk ranges from 1 to 3% in boys and 3 to 10% in girls. So as you can see, the rates of infection is lower in boys as compared to girls, but in first year of life, the rate is nearly similar in both male as well as both male and female. So this ratio is similar in first year. Then suddenly the rates of UTI increases in female child. The reason for it is short urethra, patulous uh, opening, and proximity to the anus. In girls, the first UTIs usually occur by the age of 5 years, with peaks during infancy and during the period of toilet training. In boys, most UTI occur during first year of life, and it is more common in uncircumcised boys. So, if a male child have UTI in subsequent years, then you have to deal with caution. During first year of life, male to female ratio is 2.8 to 5.4 in cases of male, to 1 in female. Beyond 1 to 2 year, male female ratio is 1 is to 10. That is significantly high in females. Infected urine stimulate an immunogenic reaction and inflammatory response, causing renal injury and scarring to the renal tissue, which is highest in children if the UTI occur in less than 2 years of age. And so it is very paramount of importance that if a child less than 2 years presented to you with UTI, you should rapidly evaluate for the chances of recurrence, possible etiology, or vesicoureteric reflex, and if there is any renal parenchymal damage, you have to treat it and prevent the renal scarring and subsequent development of hypertension and progressive renal damage to the renal tissue. So first, what is UTI? Uh, when we call it as suspected UTI, when the symptoms of UTI, pain during maturation, feeling of pain before or after urine, and if the child has fever, back pain, then there are the common symptoms where you can suspect a UTI, and then we label the child as suspected UTI before confirming the UTI. UTI is a significant bacteria, that is 10 to the power 5 ml of colonies of bacteria in 1 ml of urine of a single species in a specific sample in presence of symptoms of UTI. Recurrent UTI is recurrence of symptoms with significant bacteria in patients who have recovered clinically from the previous episode of UTI. What we call it as complicated UTI if the child having fever more than 38 degrees centigrade, that is 100 around 102 degree Fahrenheit, with features of systemic toxicity, that the child is dull, loss of appetite, nausea, vomiting. There are features of dehydration, creatinine is raised, or there is a tenderness in renal angle. Then we call it as complicated UTI. This we have discussed in. This is diagrammatic schematic representation how the what are the causes and course of UTI while dealing with a child with UTI. So gut flora has a bacterial virulent gut flora when enter the urinary system. So having a specific uropathogenic strain of E. coli colonizes the urethra and the perineum. Uh, when it colonizes the female vagina, it breaks the mucosal barrier. Here, the host defense comes into play. Most of the time, it is successful, but sometimes the host defense mucosal barrier get break, and the bacteria is able to enter the urinary system. So the host defense mechanism is uh, it breaks by increased adherence, immune status of the person, vesico-ureteric reflex, obstruction in the urinary system, foreign body in the urinary system, or previous inflammatory responses induced by recurrent infection. They are the barriers to the host defense, and they lead to the when the virulent bacteria of uropathogenic strain colonizes the urethra and perineum, enters, then it causes infection. If it is lower UTI, it causes cystitis and ascends upward and lead to acute pyelonephritis. Most of the time, it get healed, but sometimes it enters the blood and cause urosepsis. And simultaneously, if it is a recurring problem, then could lead to the scarring of the renal tissue, and sometimes can lead to hypertension and CRF in long-standing diseases. What could be the risk factor of UTI? So, as we have discussed, after 1 year, first year of life, female gender is itself is a risk factor. Where getting infected is 10 times higher than in comparison to male. When the parents or child herself is cleaning by wiping from back to front, so pulling on the stool from anal opening to the vaginal orifice, harsh toilet training, that the person that so it leads to in coordination between the various anal reflex or reflex generated by urinary system. So there is incoordination lead to lodgement of bacteria, breakage of defense mechanism, and persistence of infection. Persistence of constipation leads to incoordination of passage of stool as well as urine. Pinworm infestation, tight clothing, bubble bath, bottle-fed babies have a higher chance. Uncircumcised male have a higher chance of having UTI. Vesico-ureteric reflex, anatomical abnormality, labial adhesion, neuropathogenic bladder, obstructive uropathy, voiding dysfunction, urethral instrumentation, and unprotected sexual activity and pregnancy, they are risk factor for UTI. Features suggest underlying structural abnormality. When we feel that the bladder is distended significantly, palpable or enlarged kidney is there, phimosis is tight or vulval synechiae is there, palpable fecal mass in colon, anus is patulous, or there are few signs of neurological deficit in the lower limb, that is tone is absent or reduced, or reflex is absent. There are features of urinary incontinence, previous surgery of urinary tract leading to strictures or malformation, anorectal malformation, and meningomyelocele. They are the features, physical features, which suggest the structural abnormality in urinary system as well. Features suggestive of bowel bladder dysfunction. So this is one of the commonest reason of UTI in a otherwise well thriving child. Recurrent UTI, persistence of high-grade vesicoureteral reflux, constipation, impacted stool. So this bowel bladder dysfunction, where at one side the child is constipated, the child is not able to clean his bowels, as well as thereby impacting the bladder functioning as well. Maneuver to postpone voiding, such as Vincent's curse is squatting on heel. So these are the maneuvers to postpone voiding, especially the female child in schools, or there are chances of uh, incontinence. Avoiding, if the child is passing less than 3 times a day or more than 8 times a day, then there are chances that the child is having a bowel bladder dysfunction, that is BBD. Straining of a poor urinary stream, thickened bladder wall more than 2 millimeter of mucosa, bladder mucosa is more than 2 millimeter. If there is finding of post-viral PVR is more than 20 ml, or uh, there are spinning top configuration of bladder on micturating cystourethrogram, that is the bladder neck is a feature of obstruction. So the bladder on ultrasound or MCU, the bladder is showing the feature configuration of spinning top. Clinical features, there are three basic forms of UTI: pyelonephritis, cystitis, or asymptomatic bacteria. In asymptomatic bacteria, you find the child do not have any clinical symptoms, no pain, fever, discomfort. Uh, but on routine examination for any specific purpose, the child is found to have bacteria in her urine. Cystitis is usually a part of lower UTI, where there is a ascending infection to the bladder, and the bladder wall is thick. There is obstruction and outlet obstruction. Sometimes this infection ascends further up and lead to pyelonephritis, but pyelonephritis can be a part of systemic infection as well. So we have discussed about this pyelonephritis. Present as abdominal pain, flying fever, malaise, nausea, vomiting, and occasionally it can lead to diarrhea as well, where we call it as parenteral diarrhea. That is, the cause of diarrhea is beyond the uh, uh, intestine. In newborn, child with UTI or pyelonephritis show non-specific symptoms. The child is uh, having can have fever or hypothermic. The child is not usually stops feeding, irritable. There is features of weight loss. Jaundice is there, can be there, and the child can have sometimes be throwing up seizures as well. Pyelonephritis is the most common serious bacterial infection in children in less than 2 years of age. where we are not able to find a focus. It is a part of UTI pyelonephritis is a part of workup where we find the child is presenting to without a focus of fever. Then other we can further divide it into acute lobar nephroma where one area is in lobe is involved, renal abscess where so there is abscess in renal uh, kidney and it can be due to secondary to primary bacteremia. Perinephric abscess can be there. Uh, it uh, it could this infection can be contiguous infection in the perirenal area such as vertebral osteomyelitis or sepsis, pyelonephritis that dissect the renal capsules. Then the commonest type of UTI is cystitis, where the bladder is involved, and it is usually these patients are usually symptomatic, having specific urinary symptoms that we call it as urinary symptoms. Pain during passing urine, that is dysuria. There is urgency. There could be increased frequency of urine, suprapubic pain, incontinence, and foul urine, that is small odorous urine. Cystitis does not cause fever and does not. It is not essential to have fever with cystitis, and it usually does not result in renal injury. The diagnosis of UTI is based on positive urinary culture on a properly collected specimen of urine. While urine analysis enable a provisional diagnosis of UTI, a specimen must be obtained for urine sample must be contained for prior to the institution of antibiotics. Significant bacteria, there are 10 WBCs per cubic millimeter in an uncentrifuged urine, or more than 5 WBCs in a centrifuged sample. Leukocyturia might occur in conditions such as in febrile condition in glomerulonephritis with renal stool, presence of foreign body in the urinary tract, or many other systemic infections as well, and inflammatory conditions such as Kawasaki disease. Rapid distance based tests which detect leukocyte esterase and nitrite are useful in diagnosing UTIs. A combination of these tests has a moderate sensitivity and specificity in detecting UTI and is diagnostically as useful as microscopy. So we should collect the sample carefully after locally cleaning it, uh, but we should not clean it the area with antiseptic, or we should not force retract the prepuce because it can sometimes cause the injury to the prepuce as well. In neonate and infants, we can sometimes take sample by suprapubic aspiration or transurethral catheterization as well. The urine sample should be promptly plated within 1 hour of collection. If delay is expected, then the sample should be refrigerated at 4 degrees centigrade and can be stored up to 12 to 24 hours. Cultures from urine bags have a high false positivity, and it is not recommended to take a sample from that. A urinary culture should be repeated in case of contamination is suspected. There are mixed growth or growth of organism that normally constitute the periurethral flora, that is lactobacilli in girls, enterococci in infants and toddlers. The culture should also be repeated in situation UTI is strongly suspected but colony counts are equivocal. That is, uh, we cannot decide it is UTI or not, but you strongly clinically feel that the child is suffering from UTI or significant infection. Number of bacteria required for defining UTI depend upon the type of sample. In a suprapubic aspiration, any number of pathogen uh, we can label it as UTI, and it has a sensitivity to 99%. So even if a single bacteria is documented, then still it is a UTI. On catheterization, 50,000 and midstream urine sample, more than 1 lakh, that is 10 to the power 5. The sensitivity is midstream urine is 90 to 95%. Here you can see that catheterization and neonate, the sensitivity, if the counts is 50,000 only, still the sensitivity is 95%. With acute renal infection, leukocytosis, neutrophilia, and elevated ESR and CRP are common finding. With renal abscess, counts could be as high as more than 20-25,000. Because sepsis is common in pyelonephritis, particularly in infant, and any children with obstructive uropathy, but blood culture should also be taken. Therapy should be promptly initiated when the child is sick. Uh, uh, if the child is able to take orally, then or not sick, then oral medication can be prescribed. But the child, if you find the child is sick, not taking orally well, then the child should be hospitalized. Children less than 3 months and those with complicated UTI should be hospitalized and treated with parenteral antibiotic. Choice of antibiotics should be guided by local sensitivity pattern. Third generation cephalosporin is preferable antibiotic for uh, uh, for initiating the treatment. Empirical treatment. Therapy with single daily dose of amino glucoside may be used in children with normal renal function, where the creatinine and BUN are normal. Then you can start with single daily dose of amino glycoside as well. IV therapy is given for first 2 to 3 days, followed by oral antibiotic when the child's clinical condition get improved. Children with simple UTI and other those with 3 months of age more than our age can be treated with oral antibiotic. With adequate therapy, there is resolution of fever and reduction of symptoms by 48 to 72 hours. Failure to respond may be due to presence of resistant pathogen, complicating factor non-compliance, and these patients should require to reevaluate for UTI or the reason to find the reason of non-compliance as well. Duration of therapy is for 14 days in a child with complicated UTI, but in uncomplicated UTI, 7 to 10 days is sufficient. Adolescents with cystitis may be treated with shorter duration of antibiotics, can be up to 3 days only. Following the treatment of UTI, prophylactic antibiotic therapy is initiated in children below 1 year of age until appropriate imaginary of urinary tract is completed. Evaluation after first UTI. So there is some recent changes in this evaluation. Some feel that we should not evaluate each and every child with first UTI, but most of the author feel that the even first UTI should be evaluated thoroughly. The aim of investigation is to identify patients at high risk of renal damage, chiefly those below 1 year of age and those with VUR or UTI. So evaluation include ultrasound. So the recent changes is you should go for ultrasound for all children, and if you find that the child has significant changes of bladder or kidney or ur- uh, ureter, then you should further evaluate. Otherwise, you can have continue to wait and watch, and then you can go for DMSA as well as MCU. If there is persistence of infection or you feel that there are high chances of VUR or any other congenital defect. And ultrasound provide information on kidney size, number, and location, presence of hydronephrosis, bladder anomalies, and post-voidal residual urine in bladder. DMSA scintigraphy is a sensitive technique for detecting parenchymal infection and cortical scarring. It usually it should be done 6 months after the initial infection. MCU detect vesicular reflex and provide anatomical details of bladder and urethra. And it should be done after resolution of urinary tract infection, not during the acute phase of UTI. So this we have discussed. Ultrasound should be done soon as after UTI. MCU is recommended of 2 to 4 weeks after the UTI, and DMSA should be carried out of 2 to 3 months, and sometimes some months. Many authors says up to 4 to 6 months after the treatment. So how to prevent this recurrence as well as vesicular reflex? The person should take adequate food, fluid intake, and the person should frequently void. That is around 2 to 3 after 2 to 3 hours, maximum 4 hours. Double voiding ensures and emptying of bladder of if there is history of post-voidal residual urine. So if there is history of UTI, recurrent UTI, so yeah, it is advisable to explain about double voiding. That is, keeping the person in washroom after passing urine. Wait for 3 to 5 minutes. Then the person or child should be asked to repeat voiding, so that the voiding residual volume is reduced. Constipation, if present, should be treated. In children with VUR who are toilet trained, regular and volitional low pressure voiding with complete bladder emptying is encouraged. Circumcision reduces the chances of recurrent UTI in infant boys and might therefore have benefits in patient with grade reflux. They should not give baby bubble bath or circumcision is advisable. Prevent use of skin allergen, irritant, soaps, and cosmetic. Wiping perineum from front to back is advisable. There is some benefit of cranberry juice where you get a proanthocyanidin and tannins that reduces the chances of UTI. Clean intermittent catheterization, where the chances the, where you want the child is not able to pass urine frequently, uh, then clean intermittent catheterization to empty the bladder completely is advisable. And toilet training and behavior modification to pass urine, not to hold, to pass stool in time is advisable. Antibiotic prophylaxis in a chance if there is history of recurrent UTI, then antibiotics are recommended, especially uh, in infant where there are high chances of renal injury is there. There you can recommend quatrimoxazole in a children more than 3 months of age, especially when you have excluded G6PD deficiency. Nitrofurantoin uh, uh, is also recommended in a child more than 3 months of age, preferably more than 6 months. And here also you should exclude G6PD deficiency. And if there, as well as renal insufficiency should also be excluded. And it is very, this nitrofurantoin is very tasteless or irritant medicine. Many of the children do not like the taste of this drug and may cause vomiting and induce nausea and vomiting to the child. In first 3 to 6 months, ceflexin or cefadroxil is a alternative antibiotic to given as a prophylaxis agent. So it is recommended in UTI below 1 year of age while we are waiting for imaging studies. Vesicular reflex is documented or frequently febrile UTI where there are 3 or more episodes even if you have found the UTI urine tract is normal. So this is the diagram where this diagram is showing the reflex pattern where the bladder wall is thick, the wall is defective, so the bladder ascends up or in ureters, and this is a persistent problem that this ureter get tortuous, elongated, and the kidneys also get bubbled up and increases in size. So there is this is called a reflex nephropathy, where the bladder wall is thick. There is a documented reflex as well as elongation and tortuosity of this ureter, as well as damage to the nephrons as well as kidney. Vesicular reflex defect that allows urine to reflex from bladder through one or both ureter and up to the kidneys. Febrile VUR is seen in 40 to 50% of infants and 30 to 50% of children with UTI. And most of the time, if the VUR is of 1 to 2 grade, it usually resolves with age. It's severity graded according to the International Study Classification from 1 to 5 based on appearance of uh, bladder, ureters as well as kidney on micturating cystourethrogram. The presence of moderate to severe VUR, particularly if bilateral, is important risk factor for pyelonephritis, renal scarring, and subsequent risk of hypertension, albuminuria, and progressive kidney disease in later life. The risk of scarring is highest in first 2 years of life. So you can see that the grading, the reflex is up to the mid ureter, then in grade 2 the reflex is up to the kidney junction, then it enters to the kidney and the kidney get elongated. The ureter is getting elongated and getting tortuous. So this is how it is graded. In grade 1 and 2, antibiotic prophylaxis until 1 year of the child is 1 year of age. Restart antibiotic prophylaxis is breakthrough febrile UTI uh, is documented. Grade 3 to 5, antibiotic prophylaxis up to 5 years of age. Consider surgery if breakthrough febrile UTI is documented. Beyond 5 year prophylaxis continued if there is bowel bladder dysfunction is there. So in grade 1 and 2, you have to give prophylaxis for up to only 1 year of age, and if you find that the child again had an episode of UTI, then restart the antibiotic. In grade 3 to 5, that is 3, 4, 5, antibiotic prophylaxis is to be given up to 5 years of age. And if there is repeat breakthrough after 5 years, then consider surgery for UTI. Screening of siblings and offspring in a child found to have a reflux. Reflux is inherited in autosomal dominant manner with incomplete penetrance. Around 27% of SIBs and 35% of offspring of patients shows vesicular reflex. So if the mother or father having VUR, then one third of their children will have this VUR, and if the SIB has having VUR, then around one fourth of the SIBs will present with VUR. Ultrasonography is recommended to screen for the presence of reflex. Further imaging is required if USG is abnormal. So I think I have covered this part. Recommendation concerning the use of antibiotic for UTI prophylaxis should not be routinely prescribed for long-term. Prophylactic antibiotic should not perform routine urine culture surveillance. So you should not keep the child into repeated urinary culture surveillance without any symptoms. Clinician should not treat asymptomatic bacteria. So if you found that the child has a bacteria in the urine, but the child is do not know having no clinical symptom, that asymptomatic bacteria should not be treated with antibiotic. Clinician may use intravesical gentamicin instillation. This is a new model therapy that to be restricted with the use of by the urologist. Recommendation concerning the use of supplement should not routinely use cranberry methamphetamine, salts or ascorbic acid, probiotics or methionine for the prevention of UTI. This is also evidence is also insufficient. Use of single-use catheter or hydrophilic catheter for prevention of UTI is recommended. Clinicians should not use silver or antimicrobial coated indwelling catheter. Increased oral fluid intake is recommended. Clinician may use saline bladder irrigation for prevention of UTI in adult with spina bifida during CIC, but not using indwelling catheter. So, saline bladder irrigation is recommended in patients with spina bifida in adults, while they are doing CIC, but this saline irrigation should not be done in uh, indwelling catheters. Anticholinergics can be given, may use uh, butyl- botulinum toxin A intradiffuser therapy for the prevention of UTI, nocturnal emptying or suprapubic catheterization for emptying of UTI in adults with biafina in spina bifida is recommended. Clinician may use intravesical hydrohyaluronic acid therapy for prevention of UTI. Bacterial interference is promising but not commercially available therapy for prevention of UTI. So this can be sometime in uh, time to come has maybe a promising approach for uh, prevention of UTI. Thank you. Thank you.
Sir, like, would you like to add something or?
Uh, so, UTI is a common problem. UTI should be suspected in a child, any child presenting to you in your OPD with fever, uh, where you could not find any other possible explanation for this fever, because around 20% of the serious infection during hospital stay is found to be suffering from UTI. So UTI is one of the significant site where the infection is persisting, and we should always further investigate when as soon as we find the child with UTI, we should find the if there is any internal injuries to bladder or kidney or urethra or ureter uh, to prevent the recurrence. The child is having any other feature of which suggests that there are chances of recurrence, such as presence of spina bifida, anorectal anomalies, or gallbladder dysfunction. Then the child should be advised to get investigated further. So these are my recommendations.
Yes, sir. Thank you so much, sir, for sharing your insight on this topic, sir. I definitely think this is going to help all the participant doctors on their practice too. Sir, we have received some questions, sir. With all your permission, shall we take these questions?
Yeah, definitely.
First question is from Dr. Subramaniam. He's asking, like, I'm having a patient, female of 13 year pediatric child, and she is having VUR reflux of 2 to 3 grade, right, sir? And she is having recurrent UTIs. What are the approach we need to do after can
So,
you please?
as soon as you found that the child is suffering from UTI and having on ultrasound, you find that the vascular features of VUR, such as hydronephrosis or hydroureter, is present, then you should involve urologist into the care of this child, because if the child is 10 years or more than 10 years of age, then there could be need of use of instrumentation surgery for preventing this reflux and to
Thank you so
prevent
much.
this. Yeah,
Yes,
yeah.
sir. Sir, what are the chances of kidney damage in this? If the patient is having a regular UTI and with the reflux, what are the chances? Like, just there is a
10 to
complication.
25% chances that the child may in future, if the child, if there are chances of recurrent reflux, then we use DTPA scan should be done to find that there are features suggestive of renal damage or not, and there are high chances of hypertension, persisting kidney damage in future as well.
Thank you so much, sir, for sharing your insight to that question. Moving forward, we have another question, sir. Sir, how do you approach the choice between continuous antibiotic prophylaxis (CAP) and observation in lower grade VUR, especially considering concern about antimicrobial resistance, sir?
So this is a debatable topic, but one the consensus has not been made even after repeated discussion over many forums with in the presence of very high skilled specialist of nephrologist, urologist, pediatrician, uh, because most of the researchers say that you should give antibiotic to prevent the chances of kidney damage in future if the reflex is high. If the reflex is low, then you can wait. If there are no recurrences of UTI, then you can keep on waiting and uh, keep monitoring clinically on OPD basis for UTI.
Thank you so much, sir. And Dr. Subramaniam has written thanks for taking my questions and sharing your views. I hope, sir, it is very much helpful and it was very insightful session and important topic. Sir, as there is no more questions, sir, with all your permission, shall we conclude this webinar for today?
Thank you. Thank you for it. Thank you.
Welcome, sir, and we would like to see you in future also, sir. You always took time for the healthcare awareness and initiative, sir, and we would like to see you in future also with different topic.
Thank
Take care, sir.
thank you. Thank you for it. Thank you.
Welcome, sir.